Thanks very much, Darryl. And before you go anywhere, I know as speakers we all stand up here and thank the organisers for actually inviting us along, and I do that wholeheartedly here. But if Darryl can stand up just for a second, we're going to embarrass him for just 2 seconds. He's driven this program for the last 4 years, I think now, with a deteriorating patient focus for safety and quality. So please put your hands together for Darryl for actually getting us all together in a room. I think that's very, very important. Yes, I work at the New South Wales Clinical Excellence Commission, and thanks very much to the 3 speakers before me, because they've all talked about it, so I don't need to. And I've got a declaration. My declaration to you today is that I'm very tired. I'm very, very tired. Like all you, I work for a living. I've got 3 kids. But because of these 2 things, I've extremely sleep deprived over the last 8 weeks. And when Australia bowed out of the FIFA World Cup, I put my money on Belgium and supported them all the way to 3rd place. And I was really happy to see just yesterday morning, and that's why the last part of my sleep hasn't occurred in the last couple of days, that Geraint Thomas got up and we didn't see Chris win yet another tour. So it was nice to see a Welshman get up. And because I'm being really tired, I started Googling, like Simon suggested, and I thought, well, maybe I could start with some memes. And because I'm the 4th speaker out of 5, I knew that, quite rightly, probably most of the slides that I was going to deliver to you have already been talked about. So I'm a glass half full sort of person, Simon. I'm very happy that you and Karen and Andrew have already delivered most of this work for me. But it still remains very, very confusing. A late mentor of mine, Dr. Andrew Balesis, first talked to me about the importance of sepsis back in 1997. And I don't think we've made it any clearer, probably, in the last 21 years. We keep changing the definition, but we don't have a gold standard. We don't have a blood test. And that's what proves to be so tricky. And in my tiredness, I thought, well, maybe I could get away with doing a whole talk with just using MEMS. And so we've already talked about, Andrew's talked about the time-critical nature of sepsis. Despite this lady thinking that we don't have time for sepsis, maybe we don't have time for early goal-directed therapy, as Rivers talked about so long ago. But there's certainly some processes that we could improve in Australia about how we deliver care. And certainly ANZICS and the investigators from ANZICS have said, well, you know, most people end up with some sort of SIRS criteria. It doesn't mean that you've just got sepsis. And then with sepsis 3, the definition probably confused us more. They added Q-SOFA into the mix, and now we're still arguing about what the right definition is and whether we should use Q-SOFA. And some great organisations from around the world, NHS Wales, the UK Sepsis Trust, BC Canada and the Sepsis Network there, many others, and obviously some great work that we've heard about already from Australia, have tried to synthesise all this information and try and make sense of it. And I've been a nurse, for intensive care nurse, for over 20 years, and I remember getting my first lanyard. And I think the thing that we try and measure our quality improvement programs is can we actually summarise all the information that's needed and get it on a lanyard? Well, you can see there that NHS Wales has managed to do it. And certainly this is where we're sitting at the moment. How can we actually have a pathway that we all understand? But what I'm actually here to talk to you about is the reliability. And it's all well and good that we've got these guidelines or pathways or these amazing looking lanyards. But we need to be able to deliver that care reliably. And essentially the major factors that Greg Marchand from MedStar over in the US kindly shared this slide with me is that the human factors and reliability science isn't something that we normally do. And Kaz talked about some of the work, and it's been really pleasing to see so many of the posters outside. Process maps, Ishikawa diagrams, statistical process control charts, measuring your gains over time. I think it's absolutely fantastic. But generally what we've done is given you a guideline, given you a policy and said go out and do it, implement it. And we never stop to think about and measure the actual reliability of the implementation. We just look at some outcomes later on. We've talked a lot about standardisation. Kaz is trying to do it in Victoria. We've done it up in New South Wales with the Sepsis Kills program. and I stand here before you. Our next speaker led the program for many years, Tony Burrell, but I've got a whole team back, including the sepsis lead, Mary Fullock, back in New South Wales, minding the store, as it were. But we've managed to standardise things in terms of that in New South Wales. But poor clinical decision support is probably the biggest gap in terms of reliability. And if we don't get the information right to the right people at the right time, then this is where it falls down. And this is a definition of clinical decision support. This is one of many, but it's about providing timely information to help inform decisions. And if we do this properly, then we can affect and improve outcomes for patients. And this is the clinical decision support 5 rights. And as I said, we need some evidence-based knowledge. We need useful guidance for action. We need to get it to the right people, the right stakeholders, clinicians, as well as patients. We need to give it to them in the right sort of format, whether it's on a paper-based colour-coded chart or whether it's in our EMRs. We need to make sure that we use the right channels to deliver that information. And more importantly, or probably most importantly, is that we deliver this information to them at the right point in their workflow. There's no point giving it to them after the fact or after they've already made a decision, taken a blood culture. It's too late to say they might have a sepsis alert. So, as has already been spoken to, Tony Burrell, Mary Fullock and a team at the CEC, a very small team at the CEC, stood up a sepsis kills program in 2011. On the back of the work that Simon already referenced from 2009, looking at our incidents. And we tried to keep it quite simple. We wanted to recognise patients early. We wanted to resuscitate them appropriately with appropriate antibiotics, as Kaz has already referred to, and fluids within an hour. And we specifically put the 60 minutes there well in front of the 3 hours that promulgated around the world with our bundles. And we needed to make sure that they got to definitive care at the right time. And some of the data shows that if we get them to the right place, it actually works. What we did was we standardised a bunch of pathways for adults, maternity, paediatrics, and you can see them there, and newborn pathways as well most recently. We've revised and updated them as definitions have come out over the years, and they're freely available on the Clinical Excellence Commission website. And we've encouraged the use of them across Australia and around the world, and it's nice to see people taking them up and using them to help care for patients. And I purposely put up this meme purely because I knew I was going to piss off Tony Burrell. He's going to get up and speak to you next, and as the lead of the program for so many years, he hated the word bundle, and that's exactly why we did it. But we've given out lots of sepsis bundles. So Andrew's already put up this slide, so thank you, Andrew, for referencing this already. But what we showed when we published in 2016, and Tony was the lead author there, is that we did see a decline in the mortality from sepsis, which was absolutely fantastic. We also saw a decline in ICU hours and mean length of stay for these patients as well. But more importantly, what we saw is that if we treated them appropriately in our EDs and actually got these 12,000 odd patients to an ICU, their mortality improved even more. What happened, and you can see that little footnote down the bottom, is if we treated them appropriately and got them to the ward, we saw that their mortality increased. And that was the area that we decided we needed to start to work on. This was 2013 data. So I'm not going to talk about this slide because we've given it to Tony and I don't want to steal his thunder, but the process measure is continued to improve, and we've held the gains for the time to antibiotics in New South Wales. Tony doesn't have this slide, but we've continued to look at mortality data over the period of time that Sepsis Kills has been working in New South Wales hospitals. And you can see the data that I reported on was sitting in about 2013 here. And we've continued to see a decline in the mortality for patients that have gone through our EDs across New South Wales, and it's down to 11.3%. So Daryl's probably starting to get worried now, 15 slides in. I asked him to talk about the electronic medical record. All you're doing is talking about paper. So I've got to switch tacks pretty quickly. There's a lot of teams around the world, a lot of great teams around the world starting to look into this. And with America leading the way, arguably, in terms of implementation of an electronic medical record, by far and away more papers are coming out of the US, but there's certainly some great papers coming out all over the world. I'd encourage you to start having a look at what they're doing. But what we did in New South Wales, and it's 4 years to the day, this very day we signed off on this algorithm. We sat in a room with some great colleagues, and including the team from Western Sydney Local Health District, and we piloted this algorithm that's based on Bob Amland's work from the Cerner Corporation. I'm not here to sell Cerner. But for better or worse, the majority of our hospital systems in New South Wales are on an electronic medical record as Cerner as our vendor, so we're working with them. So Catriona's here in the audience, but other team members as well from Western Sydney worked with us to actually pilot this algorithm. And it's simply based on vital signs, white cell count, lactate and other biomarkers that we readily collect either in ED or in the wards. And we trialled this originally just by turning it on in the background. The surprising thing that we saw in a medium-sized hospital, and somewhere between 200 and 500 bed hospital, it's got an ICU, Blacktown Hospital, but we were seeing about 400 alerts for individual patients in a month. And we started to think, well, that might be a little bit high. So what we did, we developed this alert and we started putting this into some of the workflows. So this is one of the workflows. It's just a basic, like an old school whiteboard or patient tracking list in an EMR. And you can see up there Carl Jones, and these are all fake patients obviously. Carl has got a red alert there signifying that something needs to be done in terms of the sepsis alert escalation. It then comes through, and if someone doesn't action it in a very short period of time, turns red and keeps bugging the staff member until once it becomes overdue. This is a summary page that we use in New South Wales. So this is the first page that you get to as you open a patient chart in our electronic medical record. And you can see over this side the sepsis alert escalation and the overdue tasks as well that sit there to highlight that something needs to be done. And this is a very basic and the very first tool, we're talking 4 years ago now, that we started looking at, and the documentation of the actual escalation to the team. Now we've got a baseline foundational deteriorating patient program called Between the Flags in New South Wales, and so that's going to still pick up our patients, but this was specific to sepsis and we're escalating because it was a time critical emergency. The alert, once the escalation is complete, it comes off the tracking list there, and then it writes everything straight directly into our continuous docs in terms of our patient notes, and tells the clinicians what we're up to and what they've actually done. We decided to work with Macquarie University Hospital, obviously eHealth New South Wales, it helped us build the alert, and Western Sydney LHD and Blacktown to start working on this. And Catriona's probably still got the scars from trying to get the data out of a Cerner EMR, but she did it, and thanks to her and the team. And this is freely available on that website, on the Macquarie website. So here's a bit of data for you. The first part of the first aim of the evaluation was simply to look at the 3 sepsis tools that we had or that we knew about. QSOFA was the new flavour when we started this, so we had to have a look at QSOFA. We wanted to look at our paper-based adult sepsis pathway, and of course we're evaluating this new tool, this algorithm, as along the way. So you can see that we had about 36,000 patients in there, the patients that were coded for sepsis, and we were using the CHADX definitions, the hospital-acquired diagnosis definitions for sepsis, and we were simply looking at that, and you can see that the length of stay is greater, ICU admissions as a percentage are greater for those coded with sepsis, not unsurprisingly. What we were surprised about was the performance of the tools, and this was just purely looking at whether or not these tools picked up patients that were coded for sepsis. That's all we were looking at in the first round of analysis. And you can see the ROC curve there is actually better or best for our the modified sepsis alert, the electronic sepsis alert. But we were really surprised and quite pleased to see that the sepsis pathway that we had put in place so many years before was holding its own there. Not unsurprisingly, probably based on the earlier speakers, we had a poor sensitivity for our QSOFA, picking up these patients. But then we said, well, what is that clinically relevant? And Simon was in the room this conversation, and we said, well, no, just looking at codes is after the fact. So what we wanted to do is look at mortality, and the in-hospital mortality. You can see that the electronic sepsis alert outperformed QSOFA, but once again the sepsis pathway was still looking pretty good. But once we switched to looking at just the patients with severe sepsis, then we were starting to see a better area under the curve there for our electronic modified algorithm. When we looked at a combined outcome and we were looking at mortality and or an ICU admission, once again we saw a higher or better sensitivity for both our modified electronic alert as well as the sepsis pathway. QSOFA wasn't up to scratch once again, and our electronic alert outperformed the pathway, our paper-based pathway, when we were talking about severe sepsis. So the next steps, very simply, Kaz talked about this, we had to go back to the drawing board and start process mapping with our clinicians. How are we going to get the information to them at the right time? This alert just kept going off and going off and going off. We had 12,000 alerts for the 36,000 patients, and 5,000 individual patients took up those 12,000 alerts. There was simply too many. How are we going to deal with that? What we're starting to build at the moment is a bit more decision support. So what should we do next? Yes, we think that this patient's got sepsis. The senior clinician has said that they think that they've got sepsis, but what do we need to do for them ongoing? So this is about repeating a lactate in 4 and 8 hours time, appropriate blood cultures, etc. And also we've got our own sepsis antibiotic guidelines. They're freely available on the net. Have a look at them. But this is built into the system as well, and this is what we're doing right now. So the lessons learned is that we need the clinicians involved, and I'll encourage you to get involved with your EMR systems. Yes, they're clunky. Yes, they're not built for purpose. But if you don't get involved now, we're not going to get a better system in the future. You need to link with other programs like your deteriorating patient programs. They can't be separate. Sepsis can't be separate. You've got to give training to people and just in time. Don't give them training 6 months earlier and then implement something 6 months later. They're going to forget how to use the system. Catriona and the team know that data in doesn't mean data out. We put a lot of data into these EMRs and it's very, very tricky, so invest some time and resources into getting some smart people in your organisations to pull the data out. And if we don't have a clinician involved with these sepsis alerts, we simply have a deteriorating patient alert. And that's fine, that's absolutely appropriate, but unless we get a clinician involved, they don't pick up sepsis. And we can't expect that the EMR to do everything for us. It's not going to make the decisions for us. But if we concentrate all of our time looking at a computer screen and ignore our patients, we're never going to pick up the diagnosis of sepsis. This is a group out of the States that picks up big patient safety issues. It picks up all your incidents from around the world. I encourage you to have a look at it. Clinical decision support is number 3. Unrecognised patient deterioration, number 2. This is worldwide figures. Have a look at it. Be involved. And on behalf of Vicky Campbell, there's two groups that have been meeting to try and better the Cerner product that we've got across the East Coast at the very least. We're going to meet next door in, I think that's the Brisbane room, at lunchtime, and the interjurisdictional deteriorating patient group. Anyone's welcome to come and join and chat to us, but it's about sharing what we're doing and working out how we can do this better as a large scale. So thank you.